So, do we need to do introductions? Do we know everyone? Okay. The agenda, how does that look?
I apologize, I'll take you through that, I'm sorry, I'm just kind of thinking.
Okay.
You have a motion to approve the agenda?
I just wanted to add something that
Okay,
I
go
forgot to
ahead.
put on there, which would just be a report out on our annual IMT, which was the visit at the end of July with DMA, DMH, and Mercer, the governmental contractors. We had our annual review. So.
Let's make that number 8D8.
Okay.
Any other changes to the agenda? Do I hear a motion to approve?
So moved.
Second?
Second.
All those in favor say aye.
Aye.
All opposed, nay. Motion, the agenda is approved. Has everyone had a chance to look at the minutes? And I'm still, here they are. No, I'm still looking for them, frankly. Were they in the packet? You know, I just missed them.
They are
In the
they
sub- they were the
sent
supplement?
separately, but you have them in your full board packet.
Does anyone have any comments on the minutes? Do
Yeah.
you need time to read them? Hearing any comments, can I have a motion to approve the minutes, please?
So moved.
Is there a second?
Second.
Hearing nothing else any further, all those in favor say aye. Aye. Opposed, nay. Motion is approved, minutes are approved. Okay, monthly reports. Now, let you, all right, sorry about
The
that.
performance improvement grid is a sheet, looks like this. The biggest change, well, I need to apologize because I don't think it's, well, there are some updates, okay? But the end items aren't updated, but you'll notice the first item, 1A, we have met the standard for the past 7 months, so we're going to remove that item because we said that we would remove it after we met the measure for 6 reporting periods. So if that's okay with this committee, we'll remove this from the performance improvement grid. If you'll recall, we have a really good average response time in that we answer telephone calls in, I believe the current average is 7 seconds.
6.6.
6.6. So, but with the abandoned calls, it kind of dropped our rates. There are other LME-MCOs that don't count calls that are dropped in under 8 seconds. That I have raised that issue with the state regarding LME-MCOs being allowed to just determine how they're going to measure this, and so there's not really across the board a consistent way of measuring, because I think some drop in under 8, some drop in under 12, and we count every call, whether it's dropped in 2 seconds or whether it's dropped in 30 seconds. So,
Thank you for doing it that way.
the next 2 items, the complaints resolved in 30 days. We're getting much better at that. We still have to go a couple more reporting periods because of that poor March number. If you'll recall, the March number was so low because we had fewer grievances, and the ones that weren't resolved really pulled the percentage downward. Those are the major changes, except that on page 3, under number of calls determined to be urgent for which a service was provided within 48 hours, there's an update as of August 20th, and as is an issue statewide in rural areas, transportation is a big barrier to services.
On that one, again, my favorite topic, global crisis. What kind of, do we get does that include their response time?
Yes.
Okay. And is that system-wide?
Statewide. Yes,
So I mean, for us, it's system-wide, I mean, in terms of the 23 counties?
yes.
That sentence there, what was that supposed to say? He was also wearing the Smokies compliance rating.
I don't know what's below, can you open it electronically, Tommy?
What?
The,
I'm sorry.
Apparently when they updated this, they created hard row heights, and so some of the text is missing.
Hold on one second.
It's the performance improvement grid.
Yeah, I couldn't open it electronically. I was on my phone, so I'm not sure if that was a dumb device issue or not. While he's looking at that,
Actually, Duncan, you actually could not open it because I had to send you a PDF because your mailbox kept rejecting it. So I had to make it a smaller file, which is probably why you could not access the rest of that information. Julie, I'm sorry, where am I looking?
On page 3, item 2A. So
under corrective action,
Yeah, it says, while you're looking for that, it says the standard is the statewide average. You know, with our 23 counties, and I'm thinking about ECBH and whatever the one is down east.
coastal care
Yeah, I don't remember the name.
Yeah.
or
I mean,
East Point.
East Point. I mean, are the three of us almost, I mean, given that we're basically the average is, the standard is going to be, you know, we're talking about Cardinal, what is it, Wake, whatever Duke, I mean, whatever Durham and Wake is now.
Alliance.
And Alliance. And we're sitting here, I mean, how are we going to ever compete, you know, with those metropolitan areas like that? We're always going to be, and that's just concerning me, is if you have a chance, I mean, we're I don't know how I mean, if we ever meet it, it's going to be a miracle.
Statewide average?
Yeah, because the statewide average is so skewed because of those metro area ones. And it's not to say that we shouldn't strive to be there, but we ought to be judged against our rural compadres, not against the metropolitan areas.
Absolutely.
for a lot of reasons.
I think that probably if we were going to go with other rural LMEMCOs, we would be talking about Sand Hills and ECBH
Yeah.
and East Point.
Yeah.
Those,
I'm just saying,
Yeah.
what I hate is that it makes us look bad, but we're being compared to a standard that isn't necessarily realistic. Now, that doesn't mean that the state's ever going to look at realistic when it comes to rural areas, but, you know, that's kind of where we are.
the other thing that we have to remember is this is self-reporting. Smoky, as far as self-reporting to the state, we're transparent.
Well, we should be.
We're, just like the calls, we count everything. We don't delete calls under 8 seconds. So, you know, I don't know, there are problems with these measures in that the definitions of them are not
Here's
crystal clear.
Here's what I'm trying to avoid, is that we, even if it's self-reporting, let's make our measurements realistic for who we are. If the state's not mandating it, that's fine. Then let's do our own. Let's measure against ourselves against comparables. And that's not to say we shouldn't strive to always be better, but
So
let's not beat ourselves up either.
I'll ask the state if we could do it by county and classify counties as rural and urban. And then have, I think they did that one time, compared the rural and the urban, and they do that in some measures.
Or what they
But
can do
it
is
would
just
have
talk
to
about
be
the
by
rural.
counties.
Oh, really?
It would have to be by
Okay.
counties, to be fair,
There's
because
85 rural counties, 15 urban. And so it uses a rural center definition. They've already got it broken out. So now whether now maybe the state, maybe DHHS has a different formula for urban and rural, but there already is one in the statute elsewhere.
Right, but what I'm saying is not that we
Right, I
define
understand.
it, but that we measure it that way.
Right, yeah.
I understand that counties are classified, but just ask that they do the measurement that way and differentiate. I can't remember which report they did that on.
Well, didn't they, at one time, when the LMEs were area authorities, weren't their payments based on, wasn't there a higher rate for rural counties versus urban? For the
Every LME MCO had a different capitation rate, they had a different per capita rate that was calculated, I don't know how. But yes, it was population based, so if you had a denser population, your per capita rate would be lower.
All right, I have the missing part, and you're
Okay.
just looking at the last line of a couple of lines of the summary.
Well, it looks like there's something missing at the beginning, but we would have reviewed it last month, so.
Customer service, okay, how about if I just read the whole thing?
Yes,
Customer services investigating methods to improve performance. They will involve provider network in the efforts. One provider has started an open access model for anyone who walks in between 9 a.m. and 3 p.m., which will assist SMC in meeting this measure. 8/2014, transportation has been identified as a concern and will continue to be addressed. Follow-up call after appointments is already in place to improve this measure. Currently, none of the MCOs are meeting standard based on the most recent conference call with customer service. It has also, it was also learned that Smokey's compliance rate is among the highest of all MCOs.
so it's last year's state average, not the current state average.
Okay.
The performance contracts are based on the previous year's state average.
I'm just saying more of my comments were more of a generic
Right.
nature to not allow us to look as good as we are compared to like, areas, so.
There have been no other changes as there have been no other new reports. Are there any other questions or comments on this document? We can go to the July monthly report, which are the legal size papers. So if you'll recall, we had pages full of data last time because it was the end of the fiscal year, and DHHS gave us a new template that is began at the beginning of the 2014 calendar year. And so we have 7 months of measures, and there aren't any notes of concern. I know that one thing that Dr. Peck our ED readmit rate's kind of high still. If you look on Medicaid state component, which is the second page, it's 15%. So that means for people discharged from EDs, 15% were readmitted within 30 days.
Wow, that's high.
So which page is that on?
Second page,
Second page.
it's, I don't have line numbers, but
That's
it's
fine.
the
I can-
emergency department utilization, the second category from the bottom.
Thank you.
Uh-huh.
So ED admins, then the person leaving could leave because they didn't get committed, for example.
Right,
And they could leave because they were committed.
correct.
So is the ED admit readmissions, is that for either one of those categories? Okay.
And the other unfortunate number is that 56% of the people that enter the ED have providers.
Well, sure can. It's just a nightmare to run it for a frequent flyer syndrome. It's just awful.
Do we know what the state average is?
Unfortunately, we don't, because although DHHS has committed to giving us this exact document with all LME MCOs every month, we don't have, I think the last one we got was April. And they committed to giving it to us in Excel format, but they haven't. They've given it to us in a PDF format, which if you work with documents, you know that we can't filter and compare and report as easily with PDF format. It's a very work intensive, and we have to take everything out of PDF, put it in Excel if we were to complete an LME MCO comparison like we would like to do, because we think that would be really meaningful to this committee. But we are high.
So we're still high even compared to them, because there are programs that you can, they'll convert a PDF to an Excel.
Right, but with Excel, something funky happens. I don't know what it is. I know I've used it for Word.
Mhm.
I haven't used it for this. But we, until a couple months ago, we didn't even get the data since last November.
You may not be the right person to ask, but do we, given our high frequency of frequent flyers, do we have things in place that we're trying, or is it so idiosyncratic, or that's not right, but is it so unique to the individual that there is no general effort that we can do? Because this is a huge expense to us.
One of the things that we do is anyone who has had 3 or more crisis services in the past 12-month period gets a care coordinator. So care coordinators are working with these individuals. However, you know, like you said, each case is individual, and if I can find the person that's referred to me and the person is willing to cooperate with
Yeah,
the
that last
recommendations,
one,
then we have a higher success rate. But just because I find someone and they cooperate doesn't automatically mean success either, so.
Part of what we were talking about the other day when the staff came by and visited me, we're trying to deal with some issues, is I wonder if one of these we're seeing, or we believe we're seeing in our county, is so many joint agency frequent flyers, or we're dealing with the same people through the courts, DSS, and probably through Smokey. And the thought is, how can we coordinate among all the confidential information, but have the agencies working together, if you will, because it's just so many of the same people.
It is, and hopefully some of our integrated care efforts that you're going to hear about tonight will capture some individuals, because it is far less a stigma for me to go to my primary care physician than for me to walk into a clinic that's known to be for mental health. So hopefully some of our integrated care efforts will help, but we do also need to cooperate across schools, courts, and other public
That's what
agencies.
we were talking the other day about, yeah, so, okay.
It would be nice if the state would require those, this data on ED admits to be broken down in terms of the number of folks who were ED admits that were not committed versus those who were, and then to, because then you could begin to see, are the frequent flyers, if you will, the ones who didn't get committed or treated versus those who were admitted, and are those folks coming back less to us than the ones who didn't get committed? And you could equally, if you really wanted to kind of drill down to that that kind of data, you could say, you know, you could figure out, I don't know how, I'd have to think about how they would do this, but figure out how many were going to one particular hospital.
We can do that.
Can you?
We
Okay.
can do that. I made a note. We can do follow-up studies and look who has an inpatient claim immediately following an ED visit and compare it. Just the caveat here and the thing to note here is that the only data we will have are for those persons who receive Medicaid, because the state doesn't pay for ED visits. The MCO doesn't. The state.
One thing I'd be interested to know is how many of them are going in voluntarily versus involuntarily? And
To
if they,
the emergency department?
yeah, and if they go voluntarily and are committed, how many of them are voluntarily committed versus involuntarily committed? Or how many of them having their, you know, I've had peers who went to the hospital voluntarily and wanted to check themselves in, they knew they were in trouble, but yet when they checked in, something was triggered and they were admitted involuntarily.
I'm just going to be perfectly honest with you, and a lot of that has to do with transportation. Because if I don't have transportation and I need to go 2 counties away to get to a hospital, if I'm involuntarily committed, law enforcement has to transport me. That's
Oh,
the
that's so
only-
ugly though.
It is. Yes, it
ugly,
is.
but it's the
Yes, it
truth,
is.
Pat. Julie is absolutely correct in that. I mean, it is, should be criminal,
It's very sad.
but it is the case.
When I worked at a different LME-MCO, really wanted to try to get a transport service together, get a grant, so that we could transport persons who were admitting themselves voluntarily. It would cost less than doing it through law enforcement. But transportation is a huge problem in North Carolina. Transportation and housing, probably 2 of the biggest problems for people ending up in EDs, to be honest. Don't you think so, Duncan?
Well, absolutely.
Transportation and
For
housing.
sure. And there's not having access to primary care, because our folks generally burn out. There's primary care offices, they just turn them away because they don't act like a lot of the folks that come in there. It's really sad.
I'll see if we can
CCS
find
is
out
like
voluntary versus involuntarily, Pat. I don't know that I
We have
have as
that
much
now through mobile
confidence.
crisis, I'm sure we have that, but how many come in voluntarily and then move to
Right.
involuntary, that will be probably a different category. You're exactly right, Pat. It's,
It is. I went to a long-term care facility, not in the county I live in, this month to visit somebody that had been missing for a while from some of our meetings. And she ended up no longer living in the community. And she told me about the process and how devastating it really was to her, and how, you know, she was asking them to appeal, and the people dealing with her were going, well, why bother? The outcome's going to be the same anyway. And, you know, her situation and the reason she ended up being out of the community, probably, although she wasn't making really good decisions, was a domestic violence situation. And she's lost the ability to make her own decisions as a result, which, I don't know, to me, something's wrong.
it really is. You have some hospital systems, for fear of legal repercussion, will not break an involuntary petition. So there are times that mobile crisis teams will recommend breaking an involuntary petition because a person no longer meets that requirement. The hospital's so concerned about getting sued if something were to happen, if they broke that petition and something bad, there's a bad outcome, they won't break it even when it needs to be broken.
You know, and I started asking questions, and I think it's helped because she did manage to make it back to our last meeting, and I think there was a lot of things that have improved. But when I first started asking questions, before I went to see her, they had an ankle monitor on her, so that, I guess, to keep her from leaving. And she took me in a conference room when I went to see her, and she said, I want to tell you about all this. But it was already removed because I had contacted people and said, I want to go see this client, where's she at? And do I have to have permission to go see her? And she had an ankle monitor on, but it got took off. She said, you know, the strangest thing, a few days ago, they just come in and took that off of me out of the blue. You know, but it was after I'd sent some emails. But the thing was, she said she had been there before and left of her own free will. You know, it's normal to me if you've been living in the community, if you have to go in one of these places, it's normal to want to leave. It's normal to leave at some point. It's, you know, the abnormal thing to me is to make it impossible for you to ever leave. And she told me, and she's probably in her 40s, late 30s, I'll probably be here the rest of my life. Nobody paid any attention to what I had to say in these hearings. You know, and I'm going, well, you know, and she'd been there for months and hadn't had a care plan or anything. She said, but the morning I visited,
She's in one of our counties.
yeah.
We have a transition to community living.
Well, she said, all of a sudden they came in this morning and I had emailed them twice. I had a care plan this morning. They're going to try to teach me how to walk again. I said, well, you need to go through that physical therapy, and then, you know, if you still need help, maybe there are other people you can call. But, you know, I think she's getting some help now, but it was horrendous looking around at the young people in this place. That most of them probably accepted. They're going to be there the rest of their lives.
Well, that's what what they call the DOJ lawsuit is about for the state of North Carolina and the program that was created.
I'm really aware of that.
The transition to community living.
But, I mean, she's got physical disabilities as well as mental, so, you know, she may not be a prime target in that, or might not have been, but maybe she is now. But, and that's where you talk about housing being a great need, and I'm sitting there thinking, I don't know what's available in this county, but, you know, it'd be great if we had, she's somebody that's always going to need help, but she don't always have to live in an institution. You know, I was thinking maybe, you know, what does this place have? Do they have transitional housing like Oakview and McDowell or this, that, and the other? You know, we need more of those kind of places so that the consumers are not just locked away.
Well, Julie, transportation's been identified as a need. That's been a need that's almost been in the system.
Me too.
But is there something that's being done around, because that was part of the corrective action, at least the response to the corrective action plan earlier in the Tommy pointed out. Is that something?
Okay, let's do, only because I'm watching the clock, because I caused us to be so late. It's about 5 minutes to 4. And we've got to go through a lot of this report. So I want to make sure we get through those. And Julie, you do what you need to have, go through on the agenda, okay? And then we can have a discussion, because I think we're getting off part a little bit with going through these reports. And there's some we can push with. Let's go back to the transportation issue as we have time at the end of before the 4:30 meeting.
Can I ask one question on this report?
Sure, please, yeah, specific, yeah.
The number of clean claims received during the month on page 3. The percent denied looks like it almost doubled from May and June to July. Was there anything going on there that would cause that many denials to go up?
My guess is that it's place of service edits. We didn't have place of service edits in place always, and that would be my guess, but that's just totally out of the blue.
Okay. Just curious, that just seemed to be a big increase.
It is. That was a catch.
IDD dashboard. I'm assuming you were moving on.
I'm just making a note.
That's this one, right?
No, that's just a slide representation of the report that we just looked at. So I don't know if you want the spreadsheet and the slide presentation every time, or if you just want the slides.
I'll tell you what I would like. I got this and set it aside. What I really like is a highlight in bullet.
You do have that also.
I know, and I didn't see it till just now.
Oh,
Just
okay.
found it. So,
It's,
as I was looking
yeah,
through it.
when you're going through your electronic documents, it's the executive summary.
Yeah, I guess you have it, so.
Right.
Okay.
No, that's not it.
This is
Oh, that's the
the
investigation purpose.
the IDD.
IDD will be one page.
Okay, this,
Yes.
look at that. Start with the second one after that. You look on the back. See
That's
that?
the,
There it is.
Yeah.
so we have a total slot allocation of 1637 last fiscal year. July 31st was the end of the waiver year. So there was a new slot allocation. I believe that we have a slot allocation, we have an increase of 10 slots. So, but in order to get paid for one of the slots, it has to be filled, and there's a extensive evaluation process to go into filling the slots. But I think we didn't know that we were getting 10 new slots, so we are working on identifying individuals to fill those slots, as well as the slots that were open as of August 1st. Those had individuals all identified.
So the registry of unmet needs, if I'm reading this correctly, of the 910 who are eligible that you all could consider for those 10 slots, 798 are getting some kind of care, but the other 112 aren't. Is that what that
Yes.
means?
Yes.
Okay. And then we need further screening.
To determine whether they're even potentially eligible.
That's what I thought was ahead and asked. Thank you.
Any other questions?
Are there any services available for those folks waiting for services or that need further screening?
They are all, there are 2 services. I know it's respite, maybe community guide.
I was going to ask about community guide.
And that's what most of those 798 are getting. For some reason, the 112 may be waiting for something different and not want those. Although I don't know why. If a service is available to you, like respite, that to me seems like a very important service to somebody who's a caregiver.
That could be, that it's just not available in that area.
I don't know that.
Thanks.
So if there are no more questions about that, we have the operations at a glance. I think the more useful document for that is this slide document, because you can see the trends, although you have the July data. This is a very similar this is very similar information to that LME-MCO monthly report, although this is what we, again, what we created, more user-friendly. We feel like it's a more understandable format. And again, if it's ever the pleasure of the committee to discontinue bringing one of these monthly reports or bring it in a different format, just let me know.
Is there,
On page 4, around approved authorization request, there's a Y providing, seems to be, at least from March through July, trending down. Is that a typical cyclical pattern
Well, I
with
think
this, or?
one of the things that
Oh, I'm
contributes to
sorry, there's
that, yeah, the beginning part that's so low is smoky only, so.
Okay.
But the reason that I think that the authorizations are going down at this point in time is because we're doing unmanaged basic benefits now. And so people don't have to request authorizations for individual therapy and group therapy like they used to.
I got you, because the trend of people receiving services was up, but authorizations was down, but that's due to that dimension. Okay, that makes sense, thank you.
We wanted to remove a barrier to a service that we thought was, didn't need as much monitoring.
That's been widely applauded
Oh, good.
throughout the region.
Any other questions about these graphs? Alrighty then, let's see. The next we have are the quarterly reports. And I know that Carl called attention to the decrease in time, so I don't know if you want to prioritize these. If you want, or go with, just continue to go down the list.
Just go through the list, just keep working through them.
Okay. The investigation oversight report, we have a process through which we filter potential referrals for investigations and assign and track investigations. And this is a quarterly report about our activities in that area. You'll notice on the front that we have an executive summary and then followed by the graphical representation. And there's this is a new report for us, so we're continuing to try and make it more understandable. You would notice, for example, on page 5 that there are 2 graphs that talk about referral subtype, and that's because we've changed the subtypes so that they have better definitions. We can assign them into categories better. That would be an example of the improvement in this report. I think that might have been where you read, Pat, about low DSS referrals.
Well, actually, it was on the first page here in this paragraph, but, you know, not only does that concern me, it looks like to me that grievances are up for July too.
Grievance.
Well, it was on this document.
Right, we're doing a lot more education about grievances, and so having more grievances is not always necessarily a bad thing. I mean, it could be, but we want to hear about what's going on in the system so that we can address it. And you know how sometimes when you do education about something, the numbers increase?
Well, I certainly think that education is a good thing.
I would agree. So I think you'll find at the very last page is an interesting page. Of all the referrals, most of them end up in plans of correction, and in the second highest category have no findings, so that's a good thing also. We do a thorough investigation, and then the next highest is technical assistance. So you see that we're really trying to solve problems without more punitive actions. Although sometimes we do have to make notices of overpayments and suspend referrals due to health and safety reasons. Those are the smaller numbers. And I think that would be the thing to take home here. questions?
Any correlation between the providers making the referrals and no findings, or findings is a lack of different term?
I don't know about the correlation between referral source and disposition. I can.
I was impressive that they going through that was a big increase in the number of days it took to get a referral to the appropriate department right after the things combined, and that has dropped precipitously. So the good thing is we're getting into the departments for review much faster, and I hope that continues down and we get a nice low level in this number of days. So that's good. That was
Should be
impressive.
within, thank you, it should be within 48 hours.
Yeah.
That's our goal.
Yeah, it was-
Thank you for noticing that. It was intentional.
Yeah.
Grievances and complaints report is next. On the front there's an executive summary. And you can see it compared by quarter.
Let's talk about this a little bit. I mean, we had, the crew came to visit me in Rutherford, and we are, of course, trying to go to the major provider, the principal provider concept, which I understand the reasoning for, and I support. Is part of this that we should continue to see a reduction because they're more accountable, because there are fewer providers? I mean, the downside of having fewer providers is
Like a choice.
lack of choice. The upside is hopefully they're more accountable. We don't have all the small, very, very small providers who we have lots of problems with. Is that are we starting, it's too new, I think, to what we're doing to see a result. Is that going to show up in here? Because I know it wasn't mentioned in the
I don't know if
summary.
it'll show up in here, but those organizations that are comprehensive providers
That's
will
what I can remember.
increasingly have performance measures and outcome measures added to their contracts. So yes, they will have to be more accountable because it'll be outcome-based contracting. Right now we have contracts.
Right.
Then you can move to like reporting-based contracts and performance-based contracts and outcomes-based contracts. And an outcome-based and a performance-based contracts are different in that a performance-based is like a productivity, but an outcomes is where you want to get to.
And I'm talking, I know I'm talking about systemic issues here rather than individual reports. I'm not sure the report really is going to be reflective of a year from now. That's the problem with these changes in a way. But I'm also concerned that we actually, and this is not our committee's responsibility, but that we have the mechanism in place for dealing with those providers or the providers in counties where they're not meeting the standards that are being met elsewhere in the system or are expected by stuff. And so that we're not having to wait forever to get a fix. Whether it's getting the attention of the upper management to deal with the issue within that county, or frankly taking, the shotgun approach where we gotta go find another marriage.
The comprehensive providers, we meet with them monthly. So if you ever hear of any issues about what's going on in a comprehensive provider, if you contact us, we can bring it to that monthly meeting. So that usually is a fairly executive, don't you attend yours? It's an executive level
Okay.
meeting, and so it would be then, by virtue of that monthly meeting, brought to the executive level staff of the comprehensive provider. We don't have that with all providers, only our comprehensive.
And I think you're going to find two phenomena. One is that you're going to get a quicker response because you're dealing with fewer agencies. You're dealing with one versus several, so it's easier to hone in on what the issue is. The other piece is our experience as being a comprehensive provider is early on there were a lot more complaints because there was still this settling of the battlefield about what just happened.
Right, and
So-
we're still going through that.
Right, so yeah, y'all are in a different, but I'm just saying, I think you can expect, just because you see more complaints doesn't necessarily mean there are more problems. Now, it might, but there can be more complaints just because there's a settlement of the lay of the land.
It could be, I just wanted to make sure there's, I would, yeah.
But
But
I-
certainly you should see a decrease.
I just made a note to myself, though, to see the percentages of grievances and complaints that occur for comprehensive providers versus other types of providers, and we'll see if there's anything.
Yeah, I just, mine was more just, we know we're in the process of a structural change, so we'll see those in the numbers.
When you're talking about other complaints that are listed on page 3, what kind of things fall into other?
Oh, I wish I had written that down. I don't know.
Okay, maybe in the future.
I can get a list,
Um,
other complaints.
I know that we didn't have Western Highlands was not in this for Q2 of 2013-14, but since we were together at that time, was this an anomaly under abuse, neglect, and exploitation, that order, or are we seeing a significant increase in abuse, neglect, and exploitation? See, we have 22 and 13, but it had been 4. In other words, without the quarter before that,
I would have to look on that last quarter's report to find out what that was due, but I can,
that would be before Western Highlands joined, so we'd have to combine theirs with ours, right? Because to get it before October would be, you know what I'm saying?
yes, and that's January through March, so that is, all of this has Western Highlands data in it.
Yeah, I guess what I'm trying to say though is, in other words, if these numbers were an anomaly in the first column, then these two might not be
Right,
particularly high.
right.
So in other words, that one may have been particularly low for some reason, but without the quarter before it, in other words,
Right,
the July to September data last year, you don't know whether that October, December was artificially low, or whether we're now getting more because, you know what I mean? It just seems like some pretty big jumps there.
yes.
Julie, I'm also going to wonder, in response to what Mike said, this is just nothing but, I've started my sentence now that I went through I showed. I also wonder how well we integrated our data collection in that first quarter with Western Highlands and Smoky. And that was my other question, because it's pretty much across the board, there's a pretty much a jump between the first quarter and the second quarter.
Right, but, and I don't know if it was problems that happened in Smoky, but it was integrated as of October 1st. Everything went through the same system. It wasn't like we added them together. Now, if we were talking about July through September of 2013, and we were talking about Western Highlands and Smoky data, that would be adding data together from two systems. But all of this was done in one system, the Alpha system.
Okay. Anything else?
Just one question on page 5, grievance by disability type medical only seems to be increasing exponentially. Are we having provider issues, or what would be the primary?
I don't know if I
And I was wondering about this one too, Julie, but when we look at our data, and just ancillary, I think the majority of our grievances that come in are probably duly diagnosed more because it tends to be, from our agency anyway, around medication management and folks really seeking benzodiazepines and being really upset when we don't prescribe them. or start tapering them all. So it's, and again, it's just ancillary data only, but it's different than what I would have thought. Is multidisciplinary, is that dual
But these,
diagnosis?
those are your grievances to you as a provider. This would be their grieving to us about you as a provider. So we wouldn't count your grievances, and that may very well show that you handle your internal grievances well, and they don't have to come to Smoky.
Yes.
I
That
did,
helps.
I did have a CFAC member come to me after our last meeting and say she was gonna file a grievance, that she had learned where she got her mental health treatment. I guess she's wanting benzos. She would have to take a urine test. She had been to some training in Boone and talked to other folks, and they don't have to take one in Boone to get the same drugs. So she said she was filing a grievance because it wasn't done the same way everywhere. And that's gonna be, as of October, you're liable to see grievances skyrocket because they're reclassifying certain drugs that people have been able to get. I believe they class 2 for oxycodone and stuff like that is going to class 3. And everybody that has a prescription for oxycodone and some of those drugs, their prescription's going to become invalid either October the 1st or October the 6th. I know this because John just broke his back and he's been on pain pills and he got a letter, so I've been keeping up with it on TV. So all these prescriptions that are out there, a lot of them are going to become invalid in October, just automatically, when the law changes. And that might be something y'all might need to know as providers. Providers might need to know if they don't, or not on top of it is.
I guess the concern there for me on this mental health only is if it's increasing that significantly is if it's not a provider issue, then is it what you're saying, are we seeing major increase in drug seeking, and do we need to do something about that in a different way? So anyway, sorry.
I don't know, to follow up on that thing. The next is the incident reporting, quarterly report. These are reports by providers of what are classified as level 2 and level 3 incidents, and you can see there's some explanation for you.
Seems to be, even though the average on the incident count is 2.7, there seems to be
Uh-huh.
1, 2, 3,
Amazing variation.
4
Yeah.
that are in the 5 range. I would guess that Dallas would be high because we have a high number of, make sure I understand. So we have a high number of facilities in our county. This would be facility type data, some
Some of it is, yes.
right.
Mhm.
But I just wondered why, for example, Mitchell and Rutherford and Cherokee would be that high.
I was looking at that too. Cherokee, I know, has a high number of MRDV group homes, duly diagnosed. I know the group home out there, they take the highest level acuity folks that I know in the region. I don't know if that's similar in Mitchell and the other counties you were talking about. But I was wondering the same thing, if those statistics were coming out of the group homes, group home facilities more. McAllen and Mitchell, do we know if they have group homes with some high acuity folks in them?
I don't
I'm just
know,
not
but you
sure
said that you
those.
did have a high number of facilities in the county.
We've got some situations going on out there in our county.
Got 9 minutes left, I'm playing.
So, there aren't any true. So the last report that we need to go over is access to care report, the innovations annual report, and the satisfaction survey. The innovations annual report, we look at that data on quarterly report, so you can refer to it later. And that satisfaction survey summary from DHHS, that's simply the DHHS report. They gave us the data quite a while ago, and we gave this committee a report very early on. So you have seen that data and reviewed it. So the access to care report is, I think, the last one that we need to go over. And our numbers for getting services to those within 2 hours of an emergent request are right on par. Again, this is the number for urgent requests that was a concern in the initial conversation on that performance improvement grid. And then the routine care for on par. I have no idea why the first 97% under is red when it's green, 97% is green, and it's line.
Should have better done here, a different one too.
I would assume that's because your standard is 97%, it's right on the standard. Because it looks like the red is highlighting those that are below standard.
Yes,
And maybe highlighting the ones that are at standard.
except if you look at combined is 97% and it's green, so.
Oh, that's right, yeah, you're right,
I guess that, I mean, so,
I got it.
I just,
yeah. Sorry, I catch that.
no, that's okay. And then on the back of that, or the next page, there's one by county. I know, was it Pat that you had asked, regarding access calls by county?
Yeah.
Refresh my memory, as a percentage of our consumers, what percentage of substance abuse be in terms of the three categories? Involved what?
It's low. I couldn't
That's what I thought, but that's why, the reason I was asking is because as a percentage, it seems like the
Yes.
from substance abuse clients is abnormally high relative to the number of actual consumers.
They're less likely to follow up with treatment and more likely to call when they're in crisis or drinking or using.
Say that again.
Persons with a substance abuse diagnosis who don't access care within 48 hours are less likely to follow up with treatment, according to studies. And then they also are more likely to have lows either while or immediately after they use. And so they call fairly frequently. And I could call maybe 4 or 5 times before I would actually attend an appointment and not request services again. Any other questions? Okay, I have-
The providers that serve our counties, do they serve the jails as well?
Medicaid doesn't pay for services in jails, and there's very little state funds for services to be provided in the Department of Corrections.
What we do is we have encouraged the use of MOE and things like that, as we do in Buncombe and Henderson, and we try to do it in Rutherford too, is for that service for jails. What we really need is basically mobile crisis services, and what we've arranged for, which is not available in jails per se. And so what we do is we use MOE money for that purpose. Now Buncombe goes a lot farther with services and things like that. Our biggest problem is we get a crisis situation in our jail, and our guys are just not trained to deal with it, and we don't have enough staffing to deal with it. So we use mobile crisis, and we just use the MOE money for that. And surprisingly, it hasn't been as expensive as we thought. And what I hear from the correctional officers is they're so thankful. So, in terms of treatment, there is really no treatment in jail.
In the western region, there are a number of grants that have been procured to serve folks in jail. And we're just starting to do them pretty well right now. So, but they are, I mean, George's right, it's grant funded, there's no mechanism to pay for it. And you look in the newspapers, the jails are primary treatment for, not primary, but they see a lot of folks that have substance abuse and mental health disorders, and they're frequent flyers too.
And the acute, and what they keep telling me is this issue of acuity, whether it's the crimes committed or the mental health, substance abuse, chicken egg thing is much higher. And so the problems are getting worse in our county jails. Because the ones that are lower acuity, whether it's the criminal or the other, are getting bonded out very quickly, very low bonds. Because we try and keep in the ones that are the worst problems, and we're just getting a higher and higher level of acuity between the two. And it's just a horrible situation, and it's a function of money. For people who need help. All right, 427. Is there anything else for the committee? And Tommy will send out a note to those of us who are delinquent, a reminder, goal rate at 3 p.m. My apologies. So.
We're adjourned.
We're adjourned. All right. Thank you very much.
Is that an actual report document, the IMT report?
It will be, but we won't receive it until November.
Okay. Thanks.